Welcome to the Radiographics Podcast from RSNA. I'm Wendy Gibbs. This week we're covering a few related topics, new and classic. Ross Frederick will be summarizing an article on CT findings in the postoperative spine. This is a few years old, but the knowledge is increasingly essential as more and more are getting spine surgery and getting CT for evaluation. I'm going to be talking about artifact reduction techniques for these studies, which is part of that paper, as well as highlight a somewhat related paper from the newest issue, Zero Echo Time MRI, or bone MRI, in musculoskeletal imaging. This is a remarkable thing. There are so few really new imaging techniques these days, but this is. But let's start with Dr. Frederick's topic.
Postoperative spinal CT, what the radiologist needs to know. Throughout residency, I found post-op spine CTs to be quite daunting, and I would tend to avoid them, and may have even put a few back that I opened up. But it was mostly because there was just so much I didn't understand about them. After reading this article a few weeks ago and filling in many knowledge gaps, I've been finding them much more enjoyable to read. Now, it's important to be familiar with the indications for a given spinal surgery, types of procedures performed, and goals of the surgical intervention, because it aids in the accurate interpretation of post-op CT findings. The main types of spinal surgery include decompression, fixation, stabilization and fusion, deformity correction, and lesion excision and debridement. Decompression is mainly performed to minimize mass effects by removing herniated disc material or to relieve spinal or foraminal stenosis. Decompression can be achieved by performing a laminotomy, sequestrectomy, or nucleotomy if the annulus defect is surgically accessible. Unilateral laminotomy involves the removal of a portion of the lamina to gain access for stepwise removal of disc fragments and the setting of a herniated disc. Midline laminotomy, which includes the removal of the caudal part of the upper lamina and the cranial part of a lower lamina, is the standard procedure for surgical treatment of spinal stenosis. Laminectomy involves the complete removal of the lamina, and it can be unilateral in the case of hemilaminectomy with removal of one lamina, or it can be bilateral with removal of both laminae and the spinous process. This procedure can be used in extensive midline decompression procedures to relieve spinal canal stenosis. A partial facetectomy is indicated when an exiting nerve root is compressed. The goal is to remove only enough of the facet joint to decompress the nerve root without causing segmental instability, which may result in anterior subluxation. Laminectomy and facetectomy are usually accompanied by instrumentation for fixation purposes. Stabilization is performed to achieve osseous spinal fusion when there is suspected or proven instability as a result of degenerative disc disease, pars defects with spondylolisthesis, trauma, infection, and/or malignancy. In this setting, the goals of spinal implants are to immobilize the motion segment, to allow osseous fusion, maintain or restore alignment, and enable the ability to adequately address biomechanical forces after the removal of a portion of the spine. There are multiple anterior and posterior surgical approaches to the cervical spine, depending on the underlying abnormality and the level of involvement. The classic approach for the cervical spine is the anterior approach, which is used for anterior access to the C2 through T1 cervical spine levels in several procedures. A transoral approach is needed to access the clivus and the C1 and C2 vertebral bodies. The anterior approach is preferred over posterior approach because it is easier to access the disc, which can be directly visualized. However, a posterior approach can be used with the use of lateral mass screws or pedicle screws. Anterior cervical discectomy and fusion is the most commonly used technique for the surgical treatment of foraminal and central stenoses. It involves removal of the intervertebral disc and placement of an interbody cage or tricortical bone graft to restore neuroforaminal height, maintain the cervical lordosis, and promote intervertebral arthrodesis. In anterior cervical corpectomy and fusion, one or more vertebral bodies are resected. An interbody cage with bone graft material is most commonly used to replace the resected vertebral bodies. Resection of more than two vertebral bodies often requires additional posterior stabilization. Disc replacement is performed to maintain physiologic segmental motion in younger patients who do not have degenerative facet or uncovertebral arthrosis. In the lumbar spine, a posterior approach is the most common and enables access to the posterior elements, spinal canal, and disc. Indications for CT following spinal surgery include the assessment of the type, integrity, and position of spinal implants. Other indications include delineation of the relationship of the implant to the underlying spinal anatomy and abnormalities. Post-op CT can also be used to assess the spinal alignment and effects of decompression surgery on the spinal canal and neuroforamina, determine the success of intervertebral arthrodesis, and detect post-op abnormalities. Let's discuss normal post-op findings. In the immediate post-op period after spinal surgery, expected CT findings include soft tissue edema and small amounts of gas and fluid along the surgical access site and around implants and instrumentations-treated spine segments. Seromas, another normal post-op finding, are commonly observed simple collections in the surgical bed. When superficially located, they are often self-limiting and resorb over. Recombinant human bone morphogenetic protein 2, or BMP2, is a material sometimes used to promote bony fusion. When BMP2 is used at bone graft and interbody graft sites, it often incites an initial acute inflammatory response, which may result in focal osteolysis, limited end-plate resorption at the graft site, and surrounding soft tissue swelling. Transpedicular screws should traverse the central portion of the pedicle and enter the vertebral body parallel to the end plate without breaching the vertebral body cortex or having contact with neural elements and vascular structures. As an exception, sacral fixation screws may penetrate the anterior cortex for a short distance. In cervical spine instrumentation constructs, transpedicular C2 and C7 screws should have a horizontal orientation, extending anteriorly and slightly medially without breaching the pedicle cortex. Lateral mass screws in the C3 to C7 vertebral bodies should have a superior and slightly lateral orientation. After anterior cervical discectomy and fusion, the anterior cervical plate should have a lordotic contour and be flush against the vertebral bodies. There should be a distance of at least 5 mm between the superior and inferior margins of the plate and the adjacent end plates to prevent periplate ossification. The screws should be fastened such that their heads are level with the plate. In the setting of posterior spinal instrumentation constructs with screws and rods, the junction of the screw and rod should be carefully evaluated to ensure that the connector cap is completely fastened to the connector socket and the rod is engaged and aligned correctly. Angular malalignment of the rod and the connector can be a sign of construct instability. When interbody grafts are used, they should be positioned such that the distance between the radiopaque marker of the posterior graft margin and the posterior vertebral body margin is 2 mm or greater. When the interbody graft is placed closer than 2 mm to the posterior margin of the end plate, there is an increased risk of posterior migration into the spinal canal, with mass effect on the ventral thecal sac. Interbody grafts, especially standalone cages, may subside into the adjacent vertebral body for 3 mm or less before osseous fusion occurs. Depending on the length of time since surgery, various degrees of osseous bridging across bone graft placement sites occur. At 6 months following discectomy with interbody graft placement, trabecular osseous bridging should be visible on CT, either around or through the interbody graft. Similarly, after posterolateral bone graft placement with pedicle screw and rod fixation, bridging bone should be visible between the transverse processes and facet joints. 1 year after surgery, mature trabeculation and solid cortical bridging should be present across the disc spaces and posterolateral bone graft placement sites. On follow-up CT scans, asymptomatic granulation or scar tissue along the surgical tract and peridural spaces is part of the normal healing process. Epidural fibrosis is typically hyperdense in the range from 50 to 75 Hounsfield units and may partially resolve over time. Paraspinal muscle atrophy with fat replacement is a common finding. Any deviation from the expected position should be described. However, the clinical importance of variant implant positioning is unknown. Screws may breach the osseous cortex and even come in contact with the thecal sac, neural elements, or paraspinal structures, causing symptoms or adverse clinical outcomes, although the majority are asymptomatic. Therefore, it is recommended to use neutral descriptors to characterize implant positioning rather than using a word like malpositioned. However, findings of direct injury such as organ or vessel laceration, or indirect signs of injury such as fat stranding in adjacent structures, must be described and relayed in an emergent radiologist to surgeon communication. Medial angulation of pedicle screws with breach of the medial cortex may result in nerve root contact and irritation, the most common pedicle screw-related complication. In posterior cervical spine instrumentation, lateral angulation of the screw may breach the transverse foramen and damage the vertebral artery. In posterior instrumentation of the thoracic and lumbar spine, the screw can traverse the anterior cortex and come in contact with retroperitoneal structures, leading to an immediate or delayed injury. Similarly, interbody cement grafts may extend beyond the vertebral body margin to adjacent structures. The position of the interbody grafts and vertebral body plates may predict the development of future complications. Interbody grafts that are placed too close to the end plate margin may result in subsequent migration. A lateralized position of an interbody graft results in abnormal axial loading and abnormal spinal alignment. Placing an anterior plate within 5 mm of the adjacent end plate predisposes the patient to osteophyte formation. Peri-implant osteolysis of the spine may be secondary to micromotion, infection, or a foreign body reaction to polyethylene and metal products. In addition, the breakdown products of the BMP2 that is used in conjunction with interbody grafts can cause temporary end-plate osteolysis. Circumferential peri-implant osteolysis around spinal implants larger than 2 mm suggests implant loosening. However, to diagnose implant loosening with certainty, a change in the position of the implant must be demonstrated at serial imaging. Sclerosis around a screw is highly suggestive of an adaptive response to prior hardware loosening. Implant migration may result in a change in spinal alignment, such as worsening listhesis in the setting of a loose pedicle screw. Because infection can manifest with peri-implant osteolysis, it is important to distinguish infection from mechanical loosening. However, this can be challenging. The pattern of peri-implant osteolysis can help differentiate an infectious cause from a mechanical loosening-related cause. With mechanical loosening of a screw, the osteolysis may be more prominent along the distal tip owing to a pivot point around which the screw moves, whereas infectious osteolysis is often more diffuse. However, there is overlap between these two processes, and correlation of the CT appearance must be clinically correlated. The inflammatory effects of using BMP2 can result in inflammatory stranding of soft tissues and abnormal enhancement and thus mimic infection on CT. Loosening and motion of spinal implants are important contributors to unsuccessful intervertebral arthrodesis, pseudoarthrosis, and non-union, which are visible on CT due to the lack of mature osseous bridging 1 year after surgery. Pseudoarthrosis manifests as a lucent line through the intervertebral bone graft material or along the graft interface, with or without adjacent sclerosis. Following interbody graft placement, subcortical cysts, vacuum cleft phenomena, and lack of mature trabeculations across the disc space at 24 months are additional signs that suggest micromotion and pseudoarthrosis. Interbody graft migration, subsidence, resorption, and fracture after interbody graft placement also may suggest micromotion and pseudoarthrosis. In addition, failed coalition of osseous fragments and absence of bridging bone at posterolateral bone graft placement sites and in posterior elements 24 months after surgery suggests non-union. Implants can fail for a number of reasons. The implant itself can become fractured as a result of fatigue caused by repetitive stress. Fractured implants may result in micromotion and segmental microinstability, which interfere with the progression of osseous fusion. Although the implant may be intact, there can be mechanical disengagement of screws, bolts, or rods, such as those used in posterior fixations. In extreme cases, there can be loosening of a cap with a completely unsecured rod. In plate and screw fixation constructs, screws should engage with the plate to ensure compression. However, when there are multiple screws, a single failing screw may not interfere with the stability of the construct, and osseous fusion still may occur. Migration and subsidence of failing implants can cause spinal canal and foraminal narrowing, pseudoarthrosis, instability, and adjacent segment degeneration. A small degree of subsidence of interbody grafts and cages into the adjacent end plate is expected. However, subsidence exceeding 3 mm in depth is considered abnormal and can narrow the disc space and neuroforamen enough to cause radicular pain. Another complication is osseous fracture, which can occur due to weakened bone strength secondary to osteolysis, prior bone resection, and/or increased biomechanical loading through a fixation construct, and can occur around any spinal implant or prosthesis that is embedded in bone. Adjacent segment disease is the development or progression of motion segment degeneration directly above and below a spinal instrumentation construct. In adjacent segment disease, the degeneration is accelerated due to the summation of forces and result in increased transmission of the biomechanical load from the instrumentation managed and immobilized spinal segments. These segments act as a lever arm and exert torque forces at the levels of the adjacent native motion segments above and below the instrumentation construct. CT findings include disc degeneration and facet arthrosis, which may progress to spinal stenosis. After spinal surgery, post-op collections are common and include seroma, hematoma, abscess, and pseudomeningocele, which may be symptomatic or incidental findings. Epidural hematomas can exert mass effect on neuroelements and may cause pain and neurologic deficits. Non-con CT depicts a clotted hematoma as a high attenuation extradural collection with a biconvex shape. The high attenuation collection is distinct from the adjacent low attenuation epidural fat and spinal cord. Epidural hematomas usually occur dorsolateral to the spinal cord. Dural leakage with resulting CSF fluid collection, also called a pseudomeningocele, occurs in 2% of patients following laminectomy or discectomy. Pseudomeningoceles can be symptomatic owing to mass effect and accompanied by intracranial hypotension and meningitis related to CSF hypovolemia. The border of a pseudomeningocele, unlike that of a true meningocele, consists of reactive fibrous tissue. Pseudomeningoceles can extend from the spinal canal through a posterior defect at the site of resected posterior elements. On CT, it appears as a hypoattenuating collection that extends to the dura, with minimal peripheral enhancement. At laminotomy and laminectomy sites, the dural sac may protrude posteriorly and should not be mistaken for a pseudomeningocele. CT myelography can be helpful for differentiating a communicating pseudomeningocele from a seroma. Surgical site infection is an important complication that occurs most commonly during the first month following spinal surgery and could be due to direct contamination during surgery, hematogenous seeding, and implant-associated infection. These are seen as rim-enhancing collections within the surgical bed and paraspinal muscles. These are associated with extensive edema and can sometimes show gas formation. Let's recap a few key points. An interbody graft is accurately positioned when the distance between the radiopaque marker of the posterior graft margin and the posterior vertebral body is 2 mm or greater. When the graft is placed closer than 2 mm to the posterior margin of the end plate, there is an increased risk of posterior migration into the spinal canal with mass effect on the ventral thecal sac. Circumferential peri-implant osteolysis around spinal implants larger than 2 mm suggests implant loosening. However, to diagnose implant loosening with certainty, a change in the position of the implant must be demonstrated at serial imaging. The pattern of peri-implant osteolysis can help differentiate an infectious cause from a mechanical loosening related cause. With mechanical loosening of a screw, the osteolysis may be more prominent along the distal tip, whereas infectious osteolysis is often more diffuse. Adjacent segment disease is the development or progression of motion segment degeneration directly above and below a spinal instrumentation construct. These areas are most susceptible to further degeneration due to altered biomechanics.
Great. That was one of the best papers on the topic that I have seen, and I think I've read them all. At the beginning of the paper, the authors described techniques and protocols. I'm going to discuss that first. In the presence of metallic implants, CT evaluation of the spine is limited by implant-related artifacts. When the X-ray beam traverses high-attenuation implants, photon starvation, beam hardening, and beam scattering occur and manifest as dark and bright, band-like or streak-like artifacts on CT images. These artifacts limit the visibility of the implant and surrounding structures. The severity of artifacts depends on fixed and modifiable variables. Fixed variables are based on the inherent properties of the implant, including the composition and geometric features of the metal. The higher the density of the metal, the more artifact will be produced. So titanium, which is less dense than stainless steel, causes less X-ray attenuation and fewer artifacts. PEEK is a material commonly used for interbody grafts that has many useful properties, including minimal artifacts on CT. Improvement of the image quality and diagnostic accuracy of postoperative spinal CT is mainly dependent on the modifiable variables, which are related to the CT techniques, parameters, and protocols used. Several modifiable variables can be optimized to improve CT image quality in the presence of spinal implants. Performing imaging perpendicular to the implant with the X-ray beam traversing the smallest cross-section reduces the severity of artifact. Image acquisition factors that reduce artifact severity include high peak voltage, high tube current, narrow collimation, and thin sections. The peak voltage affects the ability of an X-ray beam to penetrate a structure, and the tube current corresponds to the number of photons that reach the detectors to produce the CT image. Use of a higher peak voltage and higher tube current results in fewer artifacts. However, the quadratic relationship between increasing peak voltage and increasing radiation dose should be carefully considered. In addition, the use of higher peak voltages leads to decreased contrast resolution, which can interfere with the detection of soft tissue processes. Patient motion during image acquisition also causes artifact, but is much less important these days because of the high speed of data acquisition with our current CT scanners. Acquiring CT data with use of a low pitch can decrease the severity of implant-related artifacts, and the use of smooth reconstruction kernels facilitates a decrease in noise. High spatial resolution datasets with isotropic voxels yield high image detail and enable three-dimensional post-processing. Metal implant-induced CT artifact can be further minimized by using advanced techniques, including metal artifact reduction reconstruction algorithms and dual energy data acquisition with virtual monoenergetic extrapolation post-processing. Although many vendors have their own proprietary reconstruction algorithms and metal artifact reduction software, many used projection completion. With projection completion, inaccurate or missing X-ray projections are replaced by interpolations from adjacent projections. Dual energy CT images can be acquired by using several different methods, most of which involve the use of specialized CT scanner systems. With CT datasets acquired with different tube energies, several calculations can be performed to determine the differential mass densities of the base materials. When the differential mass densities are combined with the mass attenuation coefficients, virtual monoenergetic images can be created. The acquisition of virtual monoenergetic images at higher energies reduces the severity of high attenuation beam hardening artifacts, but it does not account for other causes of artifacts such as scattering. Iterative and monoenergetic CT techniques can be used to substantially reduce spine implant and prosthesis-induced metal artifacts and improve the visibility of bone, soft tissue, and pathologic processes. The use of three-dimensional post-processing with multiplanar and curved reformations, as well as volume and cinematic rendering techniques, can further decrease the severity of streak artifact by averaging the axial data in reformation planes in which true signal and random artifacts are balanced. Now I want to briefly describe the paper in the current issue, Zero Echo Time Musculoskeletal MRI, Technique, Optimization, Applications, and Pitfalls. MRI is the preferred imaging modality for the investigation of a wide spectrum of musculoskeletal conditions and abnormalities. Although soft tissue and bone marrow are exquisitely displayed with standard MRI, small or subtle calcific deposits or osseous or ossified bodies are not. Conventional MRI pulse sequences cannot reliably depict structures such as osseous and calcified tissues with ultra-short, meaning less than 1 millisecond, T2, transverse relaxation times, because of limitations on the minimum achievable echo time. Recent developments have made the application of some novel MRI sequences that use ultra-short echo times, UTEs, feasible in the routine practice of musculoskeletal imaging. Such pulse sequences use specialized acquisition and reconstruction techniques that enable the depiction of ultra-short T2 structures. One such application is zero-TE ZTE imaging that after grayscale inversion produces CT-like images of ossified or calcified structures. This is especially beneficial in situations where a recent radiograph or CT image is not available for review at the time of the MRI, or when additional radiography or CT is warranted or helpful to complement the MRI, like evaluation before and after spine surgery. That's my connection. As with other methods attempting to generate CT-like images from MRI, ZTE imaging aims to provide enhanced cortical bone versus soft tissue contrast. Studies using the ZTE sequence, mostly on 3 Tesla, in osseous pathologic conditions of the shoulder, hip, skull, temporomandibular joint, and cervical spine have shown strong intermodality agreement between measurements and gradings made on CT and ZTE MRI images. Several other proposed MRI sequences generate CT-like bone contrast as well. Synthetic CT uses deep learning to produce CT-like images from usually a T1-weighted 3D gradient echo MRI sequence, and was recently developed with the aim of replacing CT with MRI in the planning process of external radiation therapy or correcting PET MRI attenuation. The challenges of creating quantitative synthetic CT images that accurately approximate Hounsfield units from MRI datasets are based on the inability of MRI to enable measurement of electron and physical tissue densities. While no single MRI parameter may accurately translate into Hounsfield units, a deep learning augmented approach utilizing multiple qualitative and quantitative MRI-based tissue parameters may provide an avenue to create quantitatively accurate synthetic CT images. So for spine, back to my tie-in, the surgeons will often order both MRI and CT because both are needed for full characterization of the soft tissue and osseous structures. With something like this, you could just get one test. And also, if you're evaluating a single lesion, say in the sacrum, you could just get MRI, but get the CT-like images as well with perfect registration since it's all acquired in the one exam. This is really amazing to me. I can't wait to see this as it develops. All right, that's it for this week's podcast. Check out these articles on the website and in the print journal to see the amazing images and figures. And join us on Twitter for more cases and discussion. Thanks for listening. We'll be back in 2 weeks with more summaries.